Next, let's explore Romano-Ward syndrome, RWS. This is the more common form of inherited long QT syndrome, distinct from JLNS, right?
Indeed, RWS is the autosomal dominant form of LQTS. It's characterized by that prolonged ventricular repolarization, but without the extracardiac manifestations we saw in JLNS, like hearing loss or skeletal anomalies. Its global prevalence is approximately 1 in 2,500 individuals, so much more common than JLNS. And it shows significant variability in how it presents and its severity.
What's the underlying mechanism here? Still faulty ion channels?
Yes, fundamentally it's still about those ion channels. Mutations in up to 15 genes encoding cardiac ion channel subunits have been implicated. The most frequent occur in KCNQ1, which causes LQT1, KCNH2, LQT2, and SCN5A, LQT3. These are the big three. These genetic mutations prolong the action potential duration and delay cardiac repolarization, predisposing individuals to something called early after depolarizations. This mechanism significantly increases the risk of life-threatening arrhythmias, especially during periods of physical or emotional stress. The triggers for cardiac events are actually quite distinct across the RWS subtypes, which is fascinating. For LQT1, strong emotions and physical exertion, particularly activities like running or swimming, are common precipitants. In contrast, LQT2 shares these triggers, but also includes auditory stimuli like alarm clocks, sirens, or even just a phone ringing. That can be enough. Notably, about 40% of LQT2 patients may experience events during rest or sleep. For LQT3, the majority of cardiac events actually occur during sleep or rest. Aborted cardiac arrest or sudden cardiac death can be the initial manifestation in up to 10% of untreated patients, and the typical age of SCD differs by phenotype too.
How do these different subtypes translate into different ECG patterns? Can you tell them apart just by looking at the ECG?
Well, sometimes. Studies have shown mean-corrected QDC values varying by subtype, around 466 meters for LQT1, 490 meters for LQT2, and 496 meters for LQT3. So there are average differences. However, it's crucial to remember that up to 25% of genetically confirmed LQTS patients might present with a completely normal QTC interval. That's a real diagnostic challenge. T-wave morphology also varies by mutation. LQT1 can show normal, broad-based, or even peaked infantile T-waves. LQT2 often has lower amplitude T-waves, sometimes with notching, and LQT3 T-waves can be delayed in onset or appear sort of distant from the QRS complex. So there are clues, but not always definitive. The diagnostic approach for RWS is quite similar to that for general LQTS. It includes Holter monitoring to catch intermittent changes, and of course, genetic testing to pinpoint the specific mutation. The Schwartz score, which we discussed earlier, is considered the gold standard for initial risk stratification. It helps indicate the need for genetic testing, but genetic testing remains the definitive method for identifying the specific ion channel mutations responsible for RWS.
Differential diagnosis involves distinguishing RWS from other inherited conditions like Brugada syndrome, but also, importantly, from acquired causes of QT prolongation. Things like drug-induced QT prolongation, electrolyte disturbances like low potassium or magnesium, hypothyroidism, and even ischemic heart disease can mimic the ECG findings.
So what are the key strategies for managing Romano-Ward syndrome?
Management really prioritizes arrhythmia prevention. Beta blockers, especially propranolol or nadol, are commonly prescribed. They reduce cardiac events by lowering heart rate and sympathetic nervous system activity. For high-risk patients, an ICD may be considered. Avoiding QT prolonging drugs and sudden stressors is also critical. Patients need to be aware of medications to avoid. With proactive management, the prognosis is generally favorable, but regular follow-up and consistent lifestyle adaptations are absolutely essential, especially for those identified as high-risk individuals.